again. Welcome to the teaching session of Department of Urology, Savai Mansingh Medical College, Jaipur. A very good morning again. And today we have a teaching session on a very important topic, which could be called as one of the emergencies in urology and definitely in general urology. So this will be dealt by Dr. Lokendra YADAV. He will present on PRIAPISM. And the moderator is the faculty, Dr. Somendra Bansal. And we might have Dr. Rupin Shah as an expert after the end of this presentation. So thank you once again. And thank you, Dr. Somendra. Just ask the presenter to begin the presentation.
A very good morning, all of you. Today, in continuation of our academic session, there is a seminar on the PRIAPISM, which will be presented by Dr. Lokendra YADAV. Now, I invite Dr. Lokendra YADAV to start his presentation. Dr. Lokendra, please.
Good morning, everyone. Myself, Dr. Lokendra YADAV, present seminar on PRIAPISM. Share.
Yes, Lokendra, start.
Is a full or partial erection that continues more than 4 hours. Yes, sir. Good morning, everyone. Myself, Dr. Lokendra, presenting seminar on PRIAPISM. PRIAPISM is a full or partial erection that continues more than 4 hours beyond sexual stimulation and orgasm or is unrelated to sexual stimulation. Classifying PRIAPISM is classified as ischemic PRIAPISM, stuttering PRIAPISM, or non-ischemic PRIAPISM. In ischemic PRIAPISM, there is a persistent erection marked by rigidity of the corpora cavernosa with little or no cavernous arterial inflow. In stuttering PRIAPISM, it describes a pattern of recurrence. The term has traditionally been described as recurrent, prolonged, and painful erections in men with sickle cell disease. Non-ischemic PRIAPISM, it is a persistent erection caused by unregulated cavernous arterial inflow. In it, the corpora are devinescent but not rigid, and the erection is not painful. PRIAPISM has its origin from the word priapos, who is a Greek god and is known as a god of fertility and a protector of horticulture. He is memorized for his giant phallus. Tripe in 1845 first recorded account of PRIAPISM in men described the natural history of PRIAPISM, and Frank Hinman Jr. postulated that venous stasis, increased blood viscosity, and ischemia were responsible for PRIAPISM. Burt et al. Described the non-ischemic PRIAPISM. The lifetime probability of ischemic PRIAPISM in sickle cell disease patient is about 29 to 42%, and the incidence of PRIAPISM is significantly influenced by the prevalence of sickle cell disease in a community. Majority of the PRIAPISM patients are treated in emergency department as outpatients rather than requiring hospital admission or surgery. Initial hospital stay and sickle cell disease are the major risk factor for the readmission. The evaluation and diagnosis of PRIAPISM in it. First, we take the history, and in history, we note the duration of erection, how much the time has been passed for erection. Is there any presence of pain? There any previous episodes of PRIAPISM and method of treatment? Baseline erectile functions have to be documented. Any use of erectogenic therapies, prescriptional and nutritional supplements, any use of medication and recreational drugs, any history of sickle cell disease, hemoglobinopathies, or hypercoagulable states, any history of trauma to the pelvis, perineum, or penis. And the physical examination, note the rigidity of the penis. In low flow priapism, there are rigid erections but a normal corpus spongiosum, keeping the glans penis soft. Severe pain of more than 4 hours, tenderness, and loss of elasticity of the penis also helps to identify low flow priapism. In the laboratory test, we order the routine like complete blood count, white blood count with differential platelet counts, coagulation profile. It used to assess anemia, rule out any infection, and to detect any hematological abnormalities. Sickle cell screening can be recommended in African Americans. Corporal blood aspirate differentiate ischemic from non-ischemic priapism. Aspiration is both diagnostic and therapeutic. In it, there is a dark deoxygenated blood having the appearance of a crankcase oil. Aspirated blood is sent for the pH, PO2, and the PCO2. In ischemic priapism, the pH of the blood is less than 7.25 and the partial pressure of oxygen is less than 30 and partial pressure of CO2 is less than 60, is more than 60. In non-ischemic priapism, the pH is more than 7.3, PO2 is more than 50 and partial pressure of CO2 is less than 40. Penile imaging in the color Doppler ultrasound is ordered if there is any history of penile or perineal trauma, and it is recommended in the evaluation of priapism. Color Doppler ultrasound is an adjunct to the corporal aspirate in differentiating ischemic from non-ischemic priapism. Patients with prolonged ischemic priapism will have no blood flow in the cavernous arteries. In non-ischemic priapism, the color Doppler ultrasound can demonstrate a arterial sinusoidal fistula. The penile arteriography may be used as an adjunctive study to identify the presence and site of a cavernous artery fistula. It is too invasive as a diagnostic procedure. Penile arteriography should be reserved for the management of high flow priapism when embolization is planned. MRI can be helpful in imaging of a well-established arteriosinusoidal fistula. It also demonstrates the presence and extent of any tissue thrombus or corporal smooth muscle infarction. It also helps to identify the corporal metastasis. There is a sagittal MRI of the penis showing metastatic deposits of prostate cancer to the corpus cavernosum. Coronal image of the same patient showing proximal and distal metastatic deposits of prostate cancer. Here is the differential diagnosis for the prolonged erection for more than 4 hours. It can be ischemic and non-ischemic priapism can be differentiated by taking history, penile and blood gas analysis and by penile Doppler ultrasounds. Here is the figures in the emergency department to note to manage the priapism. The etiology of ischemic priapism. Ischemic priapism accounts for the majority of cases described in the literature. The erection of ischemic priapism may begin with sexual stimulation or the administration of any pharmacological agents. Once an erection persists beyond 4 hours and is not relieved, the pathophysiological phenomena of ischemic priapism have begun. Hematological dyscharesis are a major risk factor for ischemic priapism. There are various causes of priapism. In it, the use of any vasoactive erectile agents like papaverine, phentolamine, prostaglandin E analogs, and PDE5 inhibitors. Hematological dyscharesis like sickle cell disease, leukemia, and leukemia, there are 1 to 5% chances of developing priapism. Multiple myeloma, J6PD disease. And neurogenic causes are the spinal cord injury, cerebrovascular accident, cauda-equina syndrome, compression, or any neuropathy. The various drugs also known to cause priapism are alpha-adrenergic agonist, use of psychiatric medications, any use of recreational drugs, antihypertensive drugs, or hormones. There are neoplastic, metastatic, or regional infiltration can to the penis also cause priapism. So there are toxin-mediated causes like a spider bite can also cause priapism. In metabolic causes, there disease like gout and Fabry disease can also cause priapism. In sickle cell disease, the sickle cell hemoglobinopathy accounts for 1/3 of all cases of priapism, and indeed, prevalence of ischemic priapism varies significantly within the population of males in a community with sickle cell disease. Clinical features are seen in homozygous sickle cell disease patients. The combined effects of nitric oxide scavenging and arginine catabolism result in a state of nitric oxide resistance and insufficiency termed hemolysis associated endothelial dysfunction. Contemporary science implicates that hemolysis and reduced nitric oxide in the pathogenesis of pulmonary hypertension like ulcers, priapism, and stroke in patients with sickle cell disease, whereas increased blood viscosity is believed to be responsible for painful crisis, osteonecrosis, and acute chest syndrome. Sickle cell disease priapism is also associated with reduced hemoglobin levels and increased hemolytic markers like increased reticulocyte count, bilirubin, LDH, and SGOT. And the recurrent ischemic priapism patient typically awaken with an erection that persists up to 4 hours and becomes progressively painful secondary to ischemia. It presents from childhood. Any patient who has experienced ischemic priapism is at risk for stuttering priapism. Patients with stuttering priapism will experience repeated painful intermittent attacks up to several hours before remission. Iatrogenic priapism, intracavernous injection can also result in priapism. Here, the prolonged erections are more commonly reported than priapism after therapeutic or diagnostic injections. In worldwide clinical trials of alpostadil, prolonged erections defined as more than 4 to 6 hours occur in 5% of administration, and priapism occurred in 1% of the patients. In clinical practice, intracavernous injection of trimix results in prolonged erections in about 5% to 35% of administrations. There are few case reports that have documented priapism after PDE5 inhibitor therapy. These reports suggest that men were at increased risk for priapism because of spinal cord disease, spinal cord injury, use of a PDE5 inhibitor recreationally, use of a PDE5 inhibitor in combination with intracavernous injection, or there is any history of penile trauma, or use of psychotropic medicine, or abuse of narcotics. Methylphenidate medication, atomoxetine, used in the treatment of attention deficit hyperactivity disorder may result in prolonged erection or priapism. In the molecular basis, recurrent ischemic priapism results from the nitric oxide imbalance, resulting in aberrant molecular signaling, PDE5 dysregulation, adenosine overproduction, and reductions in Rho kinase activity, translated into enhanced corporal smooth muscle relaxation and inhibition of vasoconstriction in the penis. The penile tissue, there is a progressive penile tissue necrosis and progressive fibrosis are the end stage manifestation of ischemic priapism, hampering the physical reactivity of the erectile tissue and its elasticity needed for the physiological blood engorgement. After 12 hours, there will be a trabecular interstitial edema develops. After 24 hours, sinusoidal endothelium is denuded and thrombocytes adhere to the basement membrane. After 40 to 48 hours, thrombin formed in sinusoidal spaces and smooth muscle cells undergo necrosis or become transferred to fibroblast-like cells. In the management part, medical treatment of ischemic priapism, in it the therapeutic goals are to alleviate pain about the erection, maintain determinescence, and prevent long-term complications. Management of ischemic priapism must proceed in a stepwise fashion depending upon the response to each intervention. The recommended initial treatment of ischemic priapism is the decompression of the corpora cavernosa by aspiration. Repeated aspirations can be done, and aspiration alone may relieve priapism in about 36% of patients. As the process This process leads to a marked decrease in the intracavernous pressure, and it relieves pains and remove anoxia, acidotic and hypercarbic blood. A single large bore, about 16 to 19 gauge needle should be inserted at the penoscrotal junction at 3 or 9 o'clock position to avoid piercing the dorsal neurovascular bundle. The surgeon should compress the penile shaft between the thumb and the first digit just below the 19 gauge needle, aspirating the shaft until it is soft. With the needle left in place, the shaft is permitted to refill and the compression is reapplied and aspiration is repeated. In applying the injection should not be applied over the 6 o'clock and the 12 o'clock positions. Initial corpora aspirate in ischemic priapism show dark deoxygenated blood, and the subsequent aspirations will show brighter blood. If the aspiration fails, then their intracavernous sympathomimetic drugs are used, and in it, phenylephrine is the agent of choice recommended by the American Urological Association and European Urological Association. Sympathomimetic drug with selective alpha-1 adrenergic receptor actions. It has minimal beta-mediated inotropic and chronotropic cardiac effects. It should be concentrated as 200 microgram per ml in normal saline and administered intracavernosal as 0.5 ml to 1 ml. Lower concentration should be used in children and adults with cardiovascular disease. Administration and aspiration may have to be repeated, and no recommendations can be made about maximum safe dosage. Hypertensive strokes have been reported as a complication of cumulative administration of 2 milligrams. Physician should monitor the patient for subjective complaints and objective findings consistent with known undesirable side effects, headache, chest discomfort, acute hypertension, reflex bradycardia, tachycardia and palpitations, and cardiac arrhythmia can occur. Blood pressure monitoring is recommended with repeated sympathomimetic administration. In patients with significant cardiovascular risk, ECG monitoring is recommended. Ischemic priapism is associated with sickle cell disease, requires intracavernous treatment. Hematologist may provide concurrent systemic therapies like oxygen hydration and transfusion, but the best resolution rate are achieved with therapies directed at the penis. In managing static priapism, the goal of management is to prevent the future episode. In it, oral analgesics like atropine is administered at the bedtime, and hormonal therapy like GnRH agonists and anti-androgens are also used. The hormonal therapy is contraindicated in children who have not completed their growth and sexual maturation, and those patients who are trying to conceive. Chronic GnRH or anti-androgen administration in men may affect libido or fertility and can cause gynecomastia, can cause hot flushes and promote osteoporosis, increases the risk of cardiovascular disease, and worsen sexual function. In surgical management of ischemic priapism, a surgical shunt should not be considered as a first-line therapy. Surgical treatment is considered only after a trial of intracavernous injection of a sympathomimetic has failed, or if such an attempt has resulted in a significant cardiovascular side effect. The principle of shunt procedure is to re-establish corporal inflow by relieving venous outflow obstruction. This requires a creation of fistula between the corpus cavernosa and glans penis, between the corpus cavernosa and corpus spongiosum, and the corpus cavernosa or dorsal or saphenous veins. The shunts can be described as the proximal shunts and distal shunts. The distal shunts can be the percutaneous or open distal shunts. In percutaneous distal shunts are described by the Eboch, Winter, and T-Brandt, and open distal shunts are of Algorab and corporal snake. And the open proximal shunts are by the Quackles and Scheher, and saphenous vein graft is all by the Gray Hack. A cavernogranular or corporoglanular shunt should be the first choice of the shunting procedures because it is the easiest to perform and has the fewest complications. Proximal shunting may be warranted if more distal shunting procedures have failed to relieve priapism. In winter shunt, a large bore needle or angiocatheter is placed in the distal glans and corpus cavernosum, and it can be performed in the emergency room. It has a 66% resolution rate. In EVOS shunt, it is done in under penile anesthetic block. A glans cavernosal shunt is made with a number 111 blade, and intracavernosal pressure is monitored. After skin closure, maintenance of pressure at 40 millimeter of mercury or less for about 10 minutes or more is indicative of an adequate shunt, and it has a resolution rate of 73%. In T-shaped shunt, a T-shaped cavernous glans cavernosal shunt is made by using a number 10 scalpel. In it, the blade is inserted into each corpus cavernosum from the glans, and it is turned 90 degrees laterally and then pulled out to create a T-shaped shunt. In it, the vertical incision about made 4 millimeter to 5 millimeter lateral to the meatus glans to corpus cavernosa and turn 90 degree away from urethra, and the blood is milked out. Note the difference between the EVOS and the T-shunt. In T-shunt, there is open algorab shunt, and open corporogranule shunt is indicated if percutaneous shunting fails to re-establish cavernous blood inflow. In this, excision of a circular cone segment of the distal tunica alveolinea about 5 into 5 mm is performed. In it, the transverse incision is made on the dorsal aspect of the glans, about 1 centimeter distal to the coronal sulcus, and dissection is carried down to the bulging corporal bodies. A wedge of tunica is excised, and the penis is made placid by manual compression and release. The skin is sutured with comac catgut, and it has a resolution rate about 74%. In open distal shunt, the corporal snake maneuver, it is modified algorab shunt, and it is done under GA. A 2 centimeter transverse incision made on the glans, and the distal tips of the rigid corpora cavernosa are incised and grasped, and the deoxygenated blood is milked out, and the 7 or 8 Hager dilator is advanced through the tunica to release blood and thrombus. The use of proximal shunt are used if the distal shunting fails, then proximal shunting is recommended. Proximal shunting establishes a communication between the corpus cavernosa and spongiosum at the base of penis. Shunting may also be accomplished with vein grafting to the corpora cavernosa. Venous shunts have increased Meckel's cavernous between the urethral bulb and the pleura. If placed too distal, it will not be effective and will carry a higher risk of urethral injury. In Shire cavernoso-spongial shunt, bilateral shunts are created between the urethral bulb and the pleura. The right and the left sides are separated by a distance of at least 1 centimeter in an effort to minimize the risk of urethral stricture. In cavernosal dorsal vein shunt, the deep dorsal vein is anastomosed to the tunica alveolinea. A wedge of tunica tissue is excised that is proportionate to the size of the dorsal vein. In cavernoso-sphenous shunt, the sphenous vein is mobilized by dividing and ligating its tributaries. The sphenous vein is spatulated and anastomosed to the tunica. There are higher rate of thrombosis and pulmonary embolism in this shunt. Assessing the shunt patency by visualization of bright red blood in corporal aspirate, by sending the corporal aspirate for analysis, and by color Doppler ultrasound and measurement of intracavernous pressure, and by penile compression manual, that is squeeze and release. The complication of shunts can be a penile edema, hematoma, infection. There are higher rates of erectile dysfunctions with the use of proximal shunts. There are chances of thrombosis and pulmonary embolism. The urethral fistula can occur, and the purulent cavernocytis can also occur. The immediate use of penile prosthesis in the management of priapism. The natural history of untreated ischemic priapism or priapism refractory to intervention is severe fibrosis, loss of penile length, and complete erectile dysfunction. The advantage of early penile implantation in the acute management of ischemic priapism are to preserve of penile length and the easier insertion. The clinician should document baseline erectile function, duration of priapism, or there is any history of stuttering, and prior interventions. Penile prosthesis should be considered in the following circumstances. Aspiration and sympathomimic intracavernous injections have failed, and distal and proximal shunting procedures have failed, and the ischemia is more than 36 hours. An MRI before surgery or corporal biopsy at the time of implant should be considered to document the corporal smooth muscle necrosis. There are higher rates of revision surgery and complication noted in priapism cases resulting from infection, urethral injury device, and migration and device erosion. There is a penoscrotal surgical approach for elective insertion of inflatable penile implant in a patient with severe veno-occlusive erectile dysfunction and with sickle cell disease patient. The etiology and pathology of a non-ischemic priapism. Non-ischemic priapism is much rarer than ischemic priapism. It results from a laceration or disruption of a cavernous artery or arteriole. Most common cause is a stridal injury to the crura. Other causes include coital trauma, fixed to the perineum or penis, pelvic fracture, any history of birth canal trauma to the male newborn, or needle laceration, complications of penile diagnostics, vascular erosions complicating metastatic infiltration of the corpora, or it can also be caused by iatrogenic injury. In the treatment of non-ischemic priapism, non-ischemic, it is not a painful condition, and the natural history of the non-ischemic priapism is resolution. Can occur after resolution of ischemic priapism. 62% of the non-ischemic priapism resolves with conservative treatment, and the corporal aspiration has only a diagnostic role. Initially, the non-ischemic priapism should be managed by observation. Immediate intervention can be done on patient request, but before this, discuss about the chances of spontaneous resolution and the risk of treatment-related erectile dysfunction. The Doppler sonography can be used for localization of fistula. Fistula blush can be seen with along with normal arteriograms in penile arteriography. In it, the embolization can be used. Agents used are microcoils, polyvinyl alcohol, N-butyl salicylate gel form, and autologous blood clot. Non-permanent like autologous clot and absorbable gels are preferable to permanent agents, and its success rate is about 89 to 100%, but there is a recurrence rate of 30% to 40%. The complication can be erectile dysfunction, and it is more if it is the embolization is done bilaterally. Penile gangrene, gluteal ischemia, purulent cavernositis, and abscess of the perineum can occur. And the surgical management of priapism, it is reserved for patients who do not wish to pursue expectant management, or who are poor candidates for angioembolization, or for patients in places where technology is not available, and for patients whose angioembolization is failed. And the approach is transcorporal, and intraoperative Doppler ultrasound guidance is recommended in it.
A very good morning to all of you, those who have joined us. And it's a real kind of a privileged moment for all of us to have Dr. Rupin with us in our class. And thank you, Dr. Rupin, for joining our class in the morning. And that too at such a short notice. I was just taking a chance that you might join us. So thank you for joining us. We had a small presentation on priapism by our resident, Dr. Lokendra Sharma. So Dr. Rupin, before asking anybody else to have any query, I would request you to give your brief comment on priapism. Sir, unmute yourself, please. You are muted.
I said, thank you,
Yes.
Shivam, for thinking of me. I've just heard the last 5 minutes of Lokendra's talk, so a few comments. The initial part of the management I've not heard, so I'll assume that it was covered as per the guidelines. You could have a prolonged erection of 2 to 4 hours duration, and I would distinguish that from a priapism, which I term as a priapism when a prolonged erection becomes painful. And the reason why that distinction is important is it marks a boundary between significant ischemia and non-significant ischemia. So if a person has a prolonged erection, say after an intrapenile injection of about 2 hours duration or 3 hours duration, he has no pain. Even though it is a low flow state, meaning there is very little inflow, very little outflow, there is still not much ischemia. And in that state, injecting an alpha adrenergic agent, either adrenaline 75 to 100 micrograms or phenylephrine 250 to 500 micrograms will act. Once pain sets in, which varies, but on an average after 4 hours, that is a sign that ischemia has started. And then the physiology changes. So if somebody comes, say, with an 8-hour prolonged erection, so a low flow prolonged erection, which is now painful, that is a low flow priapism. The textbooks, the guidelines, they all say that you irrigate the corpora with adrenaline diluted. I don't agree with that. In the ischemic priapism state, the main problem is lack of oxygen. And if you irrigate with adrenaline, you will cause further vasospasm of the cavernosal artery. And you do not achieve detumescence because the cavernosal smooth muscle is already paralyzed. So my recommendation for such cases is to actually do a procedure that we have described and we term external extended cavernosal drainage, EECD, in which you just stick a scalp pin into the corpora and allow the blood to drain out passively. So effectively, that is like an external shunt. And what happens is that fresh blood is coming in and flowing out, coming in and flowing out so that the tissue gets reoxygenated. And after draining 100, 200, 300 ml of blood over about half an hour, the cavernosal smooth muscle regains its contractility and then the priapism resolves. So in fact, contrary to what is published in the textbooks and the guidelines, in those patients, we do not use adrenaline. And in our experience, any low flow priapism more than 20 of up to 24 hours duration has resolved with that. Then came the interesting concept of immediate implantation. So if you have a priapism of 36 or 48 hours duration, low flow, the general experience is that these people will have permanent damage and will need a very, very difficult surgery later on. So Lokendra showed a picture of the inflatable implant as a salvage. One would never do the inflatable, though people have described it, but the majority of centers, even abroad, will use a non-inflatable because this is a tricky situation. There is ischemia, there's a greater chance of infection. You may or may not succeed, so you don't want to risk an expensive implant. One would always go in for an inexpensive non-inflatable. And after everything is settled, then one can consider replacing with an inflatable if indicated. Studies have shown that 2/3 of the patients are actually quite happy with the non-inflatable and do not ask for an inflatable. Related to that is the timing issue. When should you do it? Initially, it was recommended right away within 2 days, 3 days, but David Ralph just gave a talk in our group and they've kind of extended the time window to up to 2 weeks so that you have enough time to give the patient antibiotics, make sure that there is no infection, and then put in the implant. Finally, a last comment on the shunt. Various shunts were shown. only the distal shunt is required if you do it correctly. Proximal shunt has a high complication rate. The saphenous shunt should be indicated only if there is spongiosal thrombosis. That is the only indication for the saphenous shunt. The secret to the distal shunt working is one, the fistula between the cavernosa and the gland, and two, and this is not described or emphasized, is that post-shunt, continuously the patient has to milk the penis from the base to the tip because there is not enough pressure in the corpora cavernosa to cause a constant flow through the shunt. So when the patient milks the penis, squeezing from the base to the glands, you will actually see the blood flowing into the glands swelling up, and then the blood flowing out, and the penis collapsing. And then again, the penis becomes erect because there are no other drainage channels. And when it's erect, again, the patient squeezes from the base to the tip, the glands will swell up and the penis will detumesce. And doing this continuously over a period of several days, we'll see the priapism progressively resolving. It won't become completely flaccid, but day by day, the rigidity will go down by 10–20%. And you know that you're benefiting the patient because the ischemic pain will have disappeared. So if you do this correctly, you don't need any of the other shunt procedures. So that was a brief summary. Our last word on recurrent priapism, because that wasn't touched upon. Surprisingly, one of the treatment modalities that works in many cases of recurrent idiopathic priapism, which means there's no blood disorder, is a combination of sildenafil, which actually re-regulates the PDE5 inhibitors with finasteride. We have, I think, half a dozen such patients who have been treated for a period ranging from 6 months to now one of them is 4 or 5 years. And the management has included sildenafil, finasteride, and occasionally baclofen. So with that, thank you, Shivam. And I'll probably sign off again because this was a quick surprise.
No, thank you. Thank you very much, Dr. Rupin. If you have 2–3 minutes, I will just make a few comments. One, thank you very much for those comments about the slow extended cavernosal drainage, which is important once the ischemic paralysis of cavernosal muscle sets in. And I think this is very important because even the books and the literature tells us to inject the phenylephrine even after this duration. So, and then the acute setting penile implant, again, is a very important thing that you mentioned. And what we have developed is that once a patient is, because intracavernosal injection is probably the commonest cause for these prolonged erection priapism, as we all know that we need to see these patients in the office and need to not let the patient go before the penile detumescence occurs. So what we do is we wait for 1 hour. If the detumescence occurs, it's okay. Between 1 to 2 hours, what I have done in many of my patients is that I will ask the patient to go in a field or in a garden nearby and just run for 15 to 30 minutes. And I have seen that almost 1/3 of these patients will detumesce after this kind of a physical exercise because the blood is diverted to the limbs, and it probably helps in detumescence of the penis. And sometimes the ice pack and ejaculation might also help. If the patient comes after 2 hours, between 2 to 3 hours, then I would, we had a study which was done 20 years ago, and then we published in the International Journal of Sexual Medicine also on oral terbutaline. So oral terbutaline given 2.5 milligram, 2 tablets every 15 minutes, we have seen that again 1/3 of these patients might detumesce with oral terbutaline. If the patient comes after 3 hours, between 3 to 4 hours, then we give this injection of phenylephrine or diluted adrenaline. And if the patient comes after 4 hours, then we proceed and do the aspiration and then see whether this can help. And after 6 hours, definitely we would like to do as suggested by you, the extended cavernosal drainage, which will help in many of these patients. And I think even up to 24 hours of priapism, we have seen, and the patients have improved after this slow extended cavernosal drainage. About the shunts, what I've seen, only the modified algorab shunt, which snake maneuver, which takes care of the proximal part of the corporal body also, probably is the only thing which probably is required, and rest of the shunts are not required, because this shunt with the snake maneuver will take care of the proximal part also. So if this doesn't help, then probably we need to go ahead with a penile implant. So I would just request you, if you have a little comment on what I have developed this algorithm of.
I think that's a very nice algorithm, Shivam, and it'll help those who have to manage. Very important point which you mentioned is that if you've given an intrapenile injection, do not let the patient leave the clinic till he is detumesced one way or the other. And I think that would be the very important message. And then one can follow a staged approach as you've suggested, and that should work in most of the cases. Just one last clarification, the immediate implant is not an alternative to a failed distal shunt. What happens is somebody has had a priapism for 48 hours. You do a distal shunt, the distal shunt works, he detumesces. He's still going to have permanent erectile dysfunction. And if he comes back to you 3 months later or 6 months later, you will have a very, very difficult implant that you will have to do for him. So the concept behind immediate implantation is to avoid the difficult implant later on. So if somebody comes after 48 hours, maybe the shunt might work, and then you would do a delayed implant. Immediate implantation is an alternative approach where you don't bother to do the shunt, but just put in the implant right away, which will resolve the priapism and prevent future erectile dysfunction. But otherwise, the algorithm is a very nice one, and it should help the clinician manage the patient appropriately at the correct time.
Thank you, Dr. Rubin. If I will just mention about one of the cases that we had. We usually think that after doing all these kind of shunts surgeries, the penile cavernosal bodies will fibrose, and it will ultimately require a penile implant in almost all cases. What we had seen in this particular case, that this patient came after 24, 48 hours. We tried everything, cavernosal drainage and everything, it didn't work. Then we did a distal shunt. I was not here, but somebody from the faculty did a distal shunt. Then they did a proximal shunt also, and nothing worked. But surprisingly, after few days, after 2-3 weeks, the patient came. He said that he is starting having tumescence. And after a month or 2 months, I saw the patient is having normal erections. So after that kind of priapism, prolonged priapism, and all kinds of shunts, the patient is almost okay with his erection. So this was probably an anecdotal case, but I think we should not give hope in such patients. They might develop tumescence and erection later. Any comment on that?
Yeah, I think that's a wonderful case to teach us that we must always be cautious and that nothing is absolute in medicine. But the other way around, whenever a patient is being taken for a shunt, there should be a consent taken that he's most likely to going to have erectile dysfunction as a consequence of the prolonged priapism, and that he's aware of that. That would be very important medico-legally, because somebody like the case which you mentioned will be more a rarity and, kind of a miracle, you might almost say.
Right. Thank you, Dr. Rupin, for giving your valuable time at such a short notice. Thanks a lot, and thank you all the faculty member, all the residents who might have joined us today on Zoom and YouTube. Thank you very much. One second. Okay. Just leave it. Okay, Mr. Nimesh, thank you once again, and all of you have a good day. Thank you.